Thank you for those words of introduction. Today we'll be looking at management of complications of chronic kidney disease. And in my talk, I would like to go through CKD stages and classification because it's important to understand them. And to list the complications, go through their management, and if time permits, go through a case study together. So CKD now, as we know, is classified based on two parameters: the estimated glomerular filtration rate and the urine albumin creatinine ratio. The two screening tests which are used, one in the blood, which is serum creatinine. This is used to classify and estimate the glomerular filtration rate. And from the serum creatinine, there are online calculators which help us to calculate the estimated glomerular filtration rate based on age, sex, creatinine, and race. And most of the labs, the advantage nowadays is that report estimated GFR along with the creatinine measurement. And another test that's used to classify chronic kidney disease is the urine albumin creatinine ratio, which you've seen albuminuria being classified as either normal, moderately increased, or severely increased albuminuria. So based on the estimated GFR, we've identified 5 stages of CKD. Stage 1 is when the GFR is above 90. The normal GFR, mind you, is between 100 to 125. Stage 1 is when the GFR is above 90, but there's some structural or histological or radiological features of kidney disease. Stage 2 is when the GFR is between 60 to 89. That's a 30 mil decline from stage 1. Stage 3 is when another 30 mil decline from stage 2, that is from 30 to 59. And stage 4 and stage 5 are 15 mils per minute decline each. So stage 4 is when the GFR between 15 to 29 mils per minute, and stage 5, which used to be called end-stage kidney disease, is when the GFR is less than 15 mils per minute. So this is a classification proposed by the Kidney Disease Improved Global Outcomes, which is an international body looking at laying guidelines for management of CKD. So there are 5 grades of CKD, G1 to G5 based on the GFR, which we saw, and A1 to A3 based on the degree of albuminuria. And the higher the grade and the higher the degree of albuminuria, the worse the prognosis and increased risk of progression of CKD, as well as increased risk of complications from CKD, including cardiovascular diseases. So we'll go through the list of complications. Usually in grade 1 and 2, when the GFR is above 60 mils per minute, the only complication one might encounter is just hypertension. And from grade 3 and below, that's when GFR is below 60 mils per minute, one could encounter other complications like anemia, bone abnormalities of bone and mineral metabolism, electrolyte abnormalities like metabolic acidosis, hyperkalemia, and fluid overload. And one particular symptom which is quite troublesome for the patients in the advanced stages is pruritus. And across the stages from grade 3 onwards, there's an increased risk of cardiovascular disease and infections in CKD patients. Come to the management, first of anemia in chronic kidney disease. We know that the cause for anemia is a relative deficiency of erythropoietin, but also important to keep in mind that concomitant iron deficiency is often coexistent in patients with CKD and anemia. And it is important to identify and correct this iron deficiency before we start treatment with erythropoietin. And also there is anemia due to chronic inflammation associated with CKD. Important to identify the effects of anemia. It can cause worsening of cardiac function, worsening of cardiac failure, exacerbates left ventricular hypertrophy, and it can impair cognition and concentration. So the KDIGO recommends that in patients with CKD stage 3 and below, it's recommended to check hemoglobin once a year, and in grade 4 and 5, at least twice a year. Very often in our practice, we test more than this, but these are the recommendations, the minimum recommendations. And anemia is defined as hemoglobin less than 13 in men and 12 in women. And it is necessary to treat the anemia when the hemoglobin is less than 11 grams per deciliter. And as we saw earlier, it's important to identify iron deficiency by measuring ferritin, iron saturation, and of course rule out other causes of anemia. And before treatment with erythropoietin-stimulating agents, it is important to correct iron deficiency. And in patients with chronic kidney disease, we must understand that iron absorption is impaired from the gastrointestinal tract. And so if patients with CKD stage 3 and below have features of iron deficiency, that is, the iron saturation is less than 20%, it is recommended to give IV iron to boost up the iron stores. And the IV iron preparations that are used are iron sucrose, and nowadays we have iron carboxy maltose, which can be given less frequently. These are used to correct iron deficiency before we commence on erythropoietin-stimulating agents. So coming to erythropoietin-stimulating agents, these are agents that erythropoietin-based agents because there's a deficient state in CKD, to be used when hemoglobin is less than 10 gram per deciliter. And the preparations that we use are typically erythropoietin. This is given at doses of 50 to 100 units per kilogram 2 to 3 times per week, usually 4,000 units 2 to 3 times per week. Now we have newer analogs which are longer acting, darbepoetin, which can be given once per week, and even longer acting pegylated erythropoietin, which goes by the trade name of Mircera, which can be used even once a month. We monitor the hemoglobin once we start on erythropoietin-stimulating agent along with iron by checking the hemoglobin. The expected response is 1 gram rise every month. We must stop erythropoietin when the hemoglobin is more than 13 gram per deciliter and restart at a later lower dose when it's less than 12 gram per deciliter. Why is it important not to increase hemoglobin above 13? Because studies have shown that it is associated with increased risk of stroke, of vascular access thrombosis, and we must also not use erythropoietin in patients with an active malignancy because it is an angiogenic factor. And theoretically, there's a risk of increased hypertension in patients who use erythropoietin. Now, coming to mineral bone disease, the causes of mineral bone disease in a patient with CKD stage 3 and below are hyperphosphatemia. We know there's a deficiency of active vitamin D because 1-alpha hydroxylase, which produces active vitamin D, is synthesized in the kidneys. And these changes lead to secondary hyperparathyroidism, which lead to bone erosion and cause renal bone disease. Seen usually in CKD stages 3B and below and becomes well established in CKD stage 5. It's important to correct, not only to treat the bone disease and prevent them, but also it has been associated with cardiovascular complications, so it's necessary to treat. And KDIGO recommends checking calcium, phosphate, PTH, and ALP when the GFR is less than 45 mL per minute. And how do we treat them? With early advice on dietary phosphate, to low phosphate diet, with phosphate binders, prescription of vitamin D analogs, and in severe cases, especially in CKD stage 5 or those on dialysis, we use calcium mimetic agents like cinacalcet, and in dialysis patients, IV ethyl calcetide. And in refractory cases of severe hyperparathyroidism, tertiary hyperparathyroidism, even there are we resort to parathyroidectomy. So just in the early stages, when the phosphate is high in CKD stage 3, recommend the patient to follow a low phosphate diet, to avoid meat, cola, fast food, and canned food items, all of which are rich in phosphate. And then we use phosphate binders, which could either be calcium containing, which we use when the calcium is also low, calcium carbonate, calcium acetate. If the calcium is normal or the calcium is very high or the phosphate alone itself is very high, we use non-calcium containing phosphate binders like sevelamer, lanthanum, and the newest one in the market is sucroferric oxyhydroxide. And of course, along with treatment of hyperphosphatemia, we correct the other stimulus for hyperparathyroidism by providing active vitamin D in the form of calcitriol or alpha-calcidol, and also check for native vitamin D deficiency and correct with cholecalciferol if the level is less than 30. Now, the other metabolic abnormalities that we've seen in CKD is metabolic acidosis, which is measured which is assessed by measuring the serum bicarbonate, and KDIGO recommends treating metabolic acidosis when the bicarb is less than 22 with sodium bicarbonate. And hyperkalemia, we know, is a problem all of us encounter in CKD patients, necessary to correct when the potassium is more than 5 millimoles per liter, with a low potassium diet and an outpatient basis with potassium exchange resins. And refractory hyperkalemia patients require, we know, dialysis. So the advice regarding low potassium diet is avoidance of bananas, citrus fruits. These are very high in potassium. And the potassium exchange resins, which are used in cases of hyperkalemia, is calcium polystyrene sulfonate, the agent which is available now, and newer molecules available today in the market, patiroma, sodium zirconium cyclosilicate. These have a faster onset of action. They can be used for a longer time. They are colorless, odorless, and more palatable to the patient. So another complication is fluid overload, which is seen typically in stage 5 CKD, but can also be seen in late stage 4 CKD, and in those patients with concomitant cardiac dysfunction, it can be seen in stage 4 and below. And the treatment, of course, we all know, is with salt and fluid restriction to 1 liter per day. Important to keep in mind the thiazide diuretics like intapamide, which we use for hypertension and CKD, in earlier stages does not work when the GFR is less than 30 mils per minute, and loop diuretics can be used. Usually higher doses are needed as the CKD stage advances. And dialysis is indicated in a refractory fluid overload, which is failed with all diuretic correction, and typically in CKD stage 5, an earlier indication of dialysis in patients with a concomitant cardiac syndrome or cardiorenal syndrome. Another is pruritus, which is seen typically in CKD stage 5, which is a uremic symptom, but can also be seen in earlier stages, which is due to dryness of skin, hyperphosphatemia, hyperparathyroidism, and treated with emollients, antihistamines, refractory cases with gabapentin, and even light therapy for UV therapy has been tried. And of late, there is a therapy used in dialysis patients which is given intravenously, difelikefalin, which is a kappa opioid receptor agonist. And uremic pruritus, especially in end-stage kidney disease, is usually an indication for renal replacement therapy. Not to forget, in CKD patients, that we need to adjust many drugs, many medications according to the GFR, to avoid NSAIDs and nephrotoxic medications, and to use radiocontrast agents only when absolutely indicated, and that too with caution and protocol for prevention of contrast-induced nephropathy. We know that in hypertension, I've not touched upon this, but ACE inhibitors, ARBs, are the preferred drugs of choice to prevent progression of CKD, reduce proteinuria, and important to treat other risk factors like with diabetes. New evidence has come in for SGLT2 inhibitors, GLP-1 receptor agonists like liraglutide, utaglutide, and tirzepatide, which prevent progression of CKD as well as offer cardiovascular protection, and correct hyperlipidemia, and to provide cardiovascular risk protection with antiplatelet agent. All our CKD patients are immunocompromised, and hence it's important to prevent infections with regular vaccinations in CKD stage 4 and below, with influenza, pneumococcal, and in stage 4 and below with hepatitis B vaccination. The earlier you vaccinate, the better the immune response. Now, coming to dialysis and kidney transplantation indicated in CKD stage 5 for refractory hyperkalemia, metabolic acidosis, fluid overload, pericarditis, encephalopathy. And in Dubai Hospital, we have even a renal school where we offer early education regarding dialysis in stage 4 and below to prepare patients to psychologically accept dialysis and transplantation. And renal transplantation from stage 5 is the best form of renal replacement therapy. Skip through this for lack of time. So take-home message is to use GFR and microalbumin to diagnose CKD, and to use ACE inhibitors to prevent progression, avoid NSAIDs, promote smoking cessation, and to keep the BP under good control, diabetes under good control, LDL less than 100 with use of statins, and to avoid peripheral lines in the volar aspect of the hand in patients with GFR less than 45 or even 30, to preserve the veins for IV fistula creation, And nephrologist should be referred, patients should be referred when the GFR less than 30, and transplantation should be considered and prepared for when the GFR less than 20. And we check calcium, phosphate, PTH, and vitamin D yearly. Hemoglobin should be monitored regularly to correct iron deficiency before erythropoietin initiation, and to refer to nephrology when the phosphate is not controlled with regular measures, more than 4.5, or there's features of persistent hyperparathyroidism. Other guidelines for referral include when GFR less than 30 definitely need to be seen by a nephrologist, for rapidly deteriorating kidney function, severe proteinuria, difficult to control hypertension, for hyperphosphatemia and severe hyperparathyroidism, and for transplant evaluation at later stages. Thank you.